Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm your host, Phil Plisky. I'm a professor and founder of Coaches Club and an author at philplisky.com and a performance systems consultant in professional sports. Being a physical therapist and athletic trainer and certified strength and conditioning specialist, we like to come at this from multiple angles. We want to present the latest evidence, but most importantly, we want this to be practical for you. We want to go into the areas of our experts to really dive in and say, how do we use this in our practice the next day? I'm looking forward to this topic today. We're talking about blood flow restriction. Is it a game changer for rehab professionals? I'm joined by Johnny Owens, who's an expert in blood flow restriction. Welcome to the podcast, Johnny.
Hey, Phil. Thanks for having me. It's great to see you again, man.
Fantastic. Well, could you get us started? Tell us a little bit about your background.
Yeah, sure. So I'm a physical therapist. I've been at it over 20 plus years now. So I've seen kind of a lot of things come and go during that time, all the way from diathermy up now to this crazy thing called blood flow restriction. So I'm excited today to talk about this. My initial background coming out of school was ortho sports, and that was kind of my focus. And then I began working for the DoD at the start of the conflicts of OEF and OIF. And I was there for about 13 years and became passionate with combat casualty care and how we can return our service fighters back to duty or back to the highest level of function. And that's kind of where we stumbled into blood flow restriction and in the DoD.
I think that's actually where we first met was I came down with Dr. Tahan and the group and at the Center for Intrepid and saw that probably in its pretty early days.
Yeah, I was wondering, did you come down when we were doing it? I don't know if it was made it into.
Yes, yeah, you had just, I think you had basically just started it.
Yeah, that's awesome. The story was that one of the main groups that I was working with at the Center for the Intrepid was what we call limb salvage. And so typically when you have an IED go off or severe lower extremity trauma, most of the service members would choose to salvage their limb. Back in earlier conflicts, you might see an amputation at the MASH units or while they were still downrange. We felt it was better to get them back home when they're a little bit more lucid. They can make a decision with their family or talk to peer groups. And so most would elect to salvage. Unfortunately, that's a very long and laborious process. It can be from 1 to 3 years to actually salvage some of these limbs just from the soft tissue and bone loss. And the frustrating thing was we had about 30% that would come back after we'd had what we thought was a successful salvage, and they would amputate. And so, it was a lot of frustration on our end for the service members because of what they've gone through. And we had multiple of our guys, commit suicide during this period. Lots of them became addicted to drugs, divorce. We're putting them through the ringer trying to get back to higher level function. Should we just amputate? But then when we would look at our veterans who were, older amputees, their life wasn't always as great as, what some of our young service members would see. And it was mostly they just wanted to get that high level function now to run, jump, and hopefully redeploy, because that was kind of what a lot of them were asking us for. So we developed this exoskeleton device called the IDEO, which acted like a prosthesis. So we would put this exoskeleton on their lower leg, and it would allow a lot of them to be able to run, to jump. And, we published some papers. We reduced amputation rates by 50%. We were able to increase redeployment rates by almost 50%. But the rub was this device is really stiff, and to really make it work and not feel like your knee was going to maybe dislocate when you're trying to use it, you had to be super strong in your quad to control the knee moment. And a lot of these individuals were load intolerant, either from their injury, they didn't have muscle tissue, nervous tissue, or they had pain. So we just really were looking at, is there any other avenue other than an ACSM guideline type heavy load that we could look at? And working with a bunch of our physiologists that we had across the street in our kind of science lab, I started asking them about this thing I was reading in some of the literature, old literature, decades old, about blood flow restriction. So we got super excited as we dug into it. Luckily, across the street at that same facility was the tourniquet experts for the DOD, and they learned me up on tourniquets really quickly. We vetted for quite a while the safety and would this be okay to put this on, these severe trauma,
especially a residual limb, right? When you have a large open wound, and at what point and all that.
Well, the running joke was they were going to cut their leg off anyway. So if we made the leg fall off with this tourniquet, it would save us some time.
It would, right?
Yeah. So we got blessed and we implemented it in the DOD, and it just kind of it met all of our expectations, and just kind of proliferated from there.
That's fantastic. So I mean, that origin story is pretty amazing. Like, it came from a need, right? We need to get these folks stronger so that they can handle what they want to do. And that redeployment rate always blows my mind that so many want to redeploy. And so it came out of this need. But why is it important to discuss this for the average rehab provider? How does this fit into that?
Yeah, well, I think what we weren't expecting was the proliferation into the rehab professionals world out there. So when we were first vetting it, and then we were seeing some positive clinical results, and then publishing some trials, we started working with the APTA, asking them, would this be something that if we presented at conferences and we get asked, can I do this, or how do I do this in my clinic outside of the DOD that meets the Practice Act? Because there was a lot of things that we do. We order imaging, we can order meds, we can do all sorts of things in the DOD that don't meet the Practice Acts. And so, they did a Practice Act review for us, and came back and said, this looks like it fits within our space. This would be something that, if you're at conferences speaking, you could say they would most likely be able to do it. But the caveats were, we're not taught it in school. And so people it would be on them to make sure their personal liability is up to par, along with their professional liability of I'm going to do this new technique. And we're also not taught how to do tourniquets in school. Right. And so always work from a worst case scenario. If something goes really bad, if the lawyer, the first thing he asks you is, who taught you how to put on a tourniquet, rehab professional, and you say, I read about it, that's not going to work in court. So I think talking about it is getting awareness, because I think you should hear about it. If you read the tea leaves, this is going to be taught in universities and part of CAPTA. It sounds like I wrote a book chapter for the board exams of, pre-preparing for it to be there. So I think it behooves us to know about it. And I think it's such a powerful tool for us. And obviously I'm very biased, but I just think the writing's on the wall from the published literature and the clinical results that folks should know about it and take a deeper dive.
Absolutely. That, and it is certainly, you can always see that emerging practice first shows up when it's showing up in physical therapy school. It's probably here to stay. Yeah. So what questions should we be asking as clinicians? Like, what does this look like?
Yeah, well, I think you got to ask yourself, am I appropriate doing this? And so as a clinician, how did you learn blood flow restriction? How, did you get trained on using a tourniquet? So once you check that box, then you start asking yourself, when do I apply it, and to whom should I apply it? How long should I apply it? And we could go on for 3 days now with those questions. But, we could ask this question all the time, like, what exercises do I do with blood flow restriction? And I don't know if we need to go in kind of deeper what blood flow restriction is, but basically when you do...
Yeah, let's talk about that. I mean, so pretend I just dropped in here and I don't know what our goals or why we're doing it.
Yeah. So basically the elevator pitch is, ACSM guidelines say that to make muscle strength and hypertrophy occur in individuals, you should lift a heavy load or do an intense type of activity. And so the load is typically, 60 to 70% of a 1 RM to make any adaptive changes. And you need to do that over weeks. And that's a rub, because in rehab, most of us don't hit those targets. We might in later phases. You go to most rehab facilities that you only have the weights available to hit those kind of targets. And so then blood flow restriction is the application of a tourniquet to the proximal thigh or the proximal arm. That's an important statement right there, because tourniquets are made to go high. If you go have a surgery for an Achilles repair, they don't put the tourniquet down below your knee. They put it up because it's all plumbing. If you're using good equipment, it can shut it off. So one of the biggest complications with a tourniquet is nerve damage. So we don't want it around a superficial nerve, so we keep it high. But you put that tourniquet high on the limb, and then you reduce blood flow going into the limb. And so we typically will reduce it by around 60 to 80% in the lower extremity and by about 50% in the upper extremity. And what that does is it creates a real hypoxic environment. And so when you start lifting a lightweight under that much hypoxia, you basically choke out the Krebs cycle, and it can no longer use what its preferred muscle fiber would be for that, which is a slow twitch fiber. It physiologically can't do it. So you switch to a fast twitch fiber to lift that light load. And if we in rehab can say, I can make a post-op patient in the days or weeks post-op start using fast twitch fibers and sufficiently use them to fatigue, which we can do with blood flow restriction, we've won the anabolic jackpot. We've won the muscle jackpot.
And I think that's an important consideration there, is that what we're basically trying to bypass the system when the tissue healing will not allow us to load the tissue that it to the extent that it needs to get hypertrophy, right? Is that a kind of a bottom line there?
Yeah, that is 100%. It's people, I hate this term. They say it's almost like a biohack, but it's pretty straightforward. It's just physiologically, we know how these pathways work. One uses oxygen, one doesn't. So let's just take the oxygen away and we starve that pathway. So your body always wants to use slow twitch fibers because you don't get a reward for slow twitch. You and I are using slow twitch, just hanging around here talking and moving a little bit. We won't get muscle from that. But if we cause a significant amount of muscle stress, we'll get muscle. And then, I just want to caveat one thing you said, and it's when the tissues don't allow because they're healing, because I get this so much when I speak at conferences and things is, so this is only for postoperative patients. And it's not. So there's other conditions, there's injuries, there's people who have pain, or just generally load intolerant, and especially the elderly individuals or other comorbidities where, lifting a high load might be hemodynamically wrong for them, or their joints can't handle it, or they're just not accustomed to that. Grandma Smith might not want to just start throwing some weights around in the gym. And this is maybe a little better avenue, even from hemodynamic perspective for them.
Oh, that's fantastic. Yeah, that's great. Yeah, the applications of this are so broad, and I hope we get into some of those. So let's start us off with the research. Like what, from what I have looked into, I mean, there's pretty well like a comprehensive body of literature in this. This is not a new phenomena that we're just talking about. But can you give us the highlights of that? Give us the takeaways of that?
Yeah, well, I think what you said is important. There is a lot of literature out there. I'll get some people come up and said this new novel thing. If once they get some research behind it, I think it'll be interesting. And I always say there's a thing called the internet. There's a thing called PubMed. Might want to try it because if you do go to PubMed, there is a lot of literature. I mean, we're talking into the thousands now of papers on blood flow restriction. The first actual use of tourniquets for some conditions besides surgical was in 1927 in the Journal of JAMA. So it's an old thing. That was called Beer's hyperemia technique. Yeah. But what we have is we're kind of standing on a really great foundation with this, because what started in the published literature with blood flow restriction came mostly out of the physiologic labs, a lot of bench work. And so they went through all the mechanistic work for us and were able to say, look, this thing does increase muscle strength and hypertrophy. And if you're ever around muscle physiologists, always one thing they'll ask you is why. And so, we have these really high-powered labs that went into the why, looking at biopsies and muscle protein synthesis and satellite cell proliferation, and basically has said, yes, this thing works. And in a study I like to highlight, when people have said, well, what's the difference between blood flow restriction and lifting heavy, is I think it's from 2015. They did 12 weeks of BFR light or lifting heavy in the same individuals, so a crossover design. And they did biopsies at baseline, biopsies halfway through, and biopsies at the end. And at the end, they found the muscle strength and size were similar between the groups. They both significantly increased. But on those biopsies, there's 29 genes that are really responsible for muscle adaptation. Some need to go up, some need to go down for us to make the muscle make positive changes. And all of those genes had changed the same way between BFR and lifting heavy. So when you say, how does it get the muscle to respond like lifting heavy? It does the exact same gene expression, just it uses hypoxia and low load instead of a heavy load to make that fast twitch metabolism happen. So,
well, that's interesting because that's the thing that's different maybe than any other rehab intervention that we have, is this really does lend itself to both what I would call, the like you say, the lab research, the bench research, and clinical research. Like it allows both, and that rarely actually intersects in rehabilitation.
And it makes things undeniable. When you have this giant science-based foundation, and it's like, these aren't rehab people that were doing this. These were, physiologists and other groups who were looking, just trying to understand, is this a thing? When we first were implementing this Center for the Intrepid, we called around to some of the researchers in the U.S. that were putting out some work. And two of the three we called, they said, this has been around for years. We were wondering when you clinicians were going to finally start looking at this, and so hilarious. What we don't have a lot, and I love what you said in rehab, is a strong science-based foundation. And now this massive clinical trial foundation. If you go to clinicaltrials.gov, I think there's over 100 BFR studies going on. I have quite a few going on as well. And so that's where I hope we can take this and go to the Medicares of the world and the insurance payers and say, this is undeniable from a science aspect. Here's what the clinical trials showed. This needs a code. And we're looking at codes not just for muscle. We'd like a code for its improvements in the vascular system, potentially for controlling glucose levels in diabetics. So I think there's a lot of potential for our profession.
So you mentioned that we can really measure this physiological response. What is that physiological response that is actually happening? What are those factors that occur?
Yeah, so whenever you work a muscle where it has to move into that fast twitch metabolism, you get several things that happen. So one of them is you'll get a lot of muscle metabolites that start to cleave off. And so as you're a byproduct of fast twitch metabolism, using that glycolytic pathway, is that you will get lactate and hydrogen ions that are created in the muscle. So you create this real acidity while you're doing it. And that's this muscle stress that I talked about. And so that muscle stress becomes a signal for things like a pituitary gland, which will increase growth hormone when it starts to see acid in the muscle. And we also see, and I think we'll talk about it a little bit later, an endogenous opioid release. But we also will start to see a proliferation of the muscle stem cells. And then on down the line, hours later, we'll see this drive of muscle protein synthesis. So if people want to say, how does muscle get bigger over time? It would be that you increase its myocyte content, which is a proliferation of those muscle stem cells. You increase muscle protein synthesis is what makes the muscle hypertrophy. And so some people say, well, I don't really care about this muscle hypertrophy. I care about strength. I get it. And the BFR studies show that we increase strength as well. But what's different with the way we are looking at it compared to a lot of my muscle physiology friends is we're watching people lose muscle daily. It happens, within 3 days, you're already seeing changes on MRI with muscle. And so by just keeping that muscle on, it puts us so far ahead of the game. And now we're looking at reducing, return to play, return to duty, return to work times by keeping that muscle on. And it helps with things like bone as well. So that's kind of some of the physiological pathways that I think are kind of impressive.
That's incredible. I mean, the idea that you can do that, and we've got to keep coming back to the fact that it's under a safe low load. Like that's a very big deal. Like that is really the difference between, traditional heavy weightlifting, like you said, and what we're doing with BFR. All right. So how do we translate this into the clinic though? I mean, I think the physiology, I love the science background. I think it's important for all of us to know, but bottom line, I have to get this into the clinic. What's the research say? When I should be using it, who's it appropriate for, and what does it do? Like, what are the outcomes? How does it translate into what we're looking for?
Yeah. And well, I would say first, getting it into the clinic, no one is as big of an expert on low load exercise as rehab professionals. unfortunately. And so if you're going to look out there,
Wait, Johnny, you do have to put a little bit of a clarification on there. It is and I'm not going to say low load. I'm going to say underloaded exercise.
low load,
I'll even take it a step. I'll take it a step farther.
Yeah.
Not appropriately loaded exercise. How
We
about
brought
that?
some of our scientists in the early days from across the street to kind of look through our exercises, see where we were maybe missing things. They were watching some of our guys on the mat doing their mat exercises and things. And they asked if those were the further range of motion for their hip, like doing their hip abduction, because they couldn't believe we were calling these things strength exercises. Now, if you throw a tourniquet on that, it changes the game. And, I know, Phil, you're familiar with blood flow restriction, and I'm going to say this, it is low load, but it is highly intense to do it. And so, I don't know if you remember coming to our place, and we have tough dudes in there who were moaning and groaning, lifting very light weights with a tourniquet on.
Yeah, with 5 pounds on their look sounds like a max squat right in there.
Yeah. So that's what people need to understand is it is hard. If you're doing it right, you have a right system where it's really occluding blood flow and you get this hypoxic state. You're having to recruit fast twitch fibers. And some people haven't done that maybe ever or years.
Right.
And so it's a new feeling to them. And you're kind of tapping out the energy systems as well. So like the phosphagen system is a like the rocket fuel. It's the one that you use to get those first few reps up, or if you heard the mom lifted the car off the kid, that's that real high power system. It really relies on oxygen, and it really gets buffered down with the lactate. So that system goes away. So people are having to pull from energy systems they haven't used before. So it's very hard and intense, but it's very safe on their injury. So I think you just need to make sure the patient would be able to handle, what's going to feel like a heavy lifting session to them, even though it's very light. And you can ease them into it. So I hear people, like I did it on my patient and they said it was terrible. And I talked to them and they're like, yeah, well, we did 4 exercises the first day. So, I would always start with one blood flow restriction exercise and then build the person up to it. We control pressures, of how much arterial occlusion we take out. So the more occlusion, lots of times the harder it is. And so you can start at a lower pressure and build them up to get used to the tourniquet. You remember your patient has probably never felt a tourniquet while they have been under anesthesia, right?
Yeah.
So it is a very uncomfortable and weird feeling at the start. But some studies have shown over a week or two that rate of perceived exertion attenuates down. They start to get used to it and accustomed to it, and then you can really start to go. They've even measured cortisol levels. When you start BFR, they're really high, but then over time they attenuate down. So the stress of it starts to attenuate down. So you can ease these people into it as well. As far as,
awesome.
Where do you use it or when would you use it? We had a saying at the Center for the Intrepid. ACSM says you should lift around 70% of a 1 rep max to make positive muscle quantity and quality changes. If you're doing an exercise and you're saying, I'm doing this for strength and hypertrophy, then ask yourself every time, am I following ACSM guideline loads? If you say no, then we say put a tourniquet on it, because it's undeniable in the literature. I think we have 79 systematic reviews and meta-analysis that have looked at blood flow restriction. It always beats.
So pause there for a second. So don't gloss over that. So you said 79, not studies. You said systematic reviews and meta-analyses, right?
Yeah.
So that's a lot. That's robust.
Yeah. It's one of my favorite slides when I speak is showing that, I have to update it like almost every couple of weeks because a new one comes out. And we know some of these are always garbage. You and I have been in the world, but there is a robust amount of studies that they can get that many systematic reviews and many with meta-analysis.
So let's take, if we were to kind of just even dive into those, what are the conditions that, so we go from general and say, boy, if you can't achieve that load that you should be for whatever reason, fill in the blank, you should be using it. But what are those conditions? What are the conditions that have been studied that we can pretty well hang our hat on and say, these are things you should seriously consider?
Yeah, clinically, the knee has been most looked at, especially for ACL. And if you look at the clinical trials that are ongoing, We have a new almost $2 million grant to study ACLs and look at long-term changes right now down at our base. So ACL probably has the most data and has positive data in most of these trials. One of the problems with blood flow restriction I'll throw out is, it's, if you look at a drug trial, it's everyone takes the same dose, gets the same drug, or they get a placebo. When you look at some of these blood flow restriction trials where people are like, oh, did you see this? And it's like, they use like a blood pressure cuff, which isn't going to hold pressure. They didn't measure like how much, arterial occlusion to do, because everyone's different on how much pressure they should take. And so I would say it'd be like a drug trial where you said, well, this drug didn't work. And it's like, well, some people got 20 milligrams, some people got 50, some people got, and so I think
from a pure load perspective, right? So if you haven't, so you need dosing in two different areas, the occlusion as well as the load on the limb, right? Because it doesn't take away the need. It doesn't take away the need to use our ACSM guidelines, right? Of what it looks like. That doesn't go away. So you still have to dose appropriately.
Exactly. Oh, that's the biggest. It's one of the biggest flaws I see as well. Is people blood flow restrictions hard on an easy day with no weight, and they'll just kind of stay in this, maybe they dialed in their occlusion right, but they keep the load too low, and it has to follow the same kind of loading parameters which you would with any resistance program. So, I would
probably has the same accommodation too, meaning, as if you started with lifting 100 pounds, if you kept lifting 100 pounds for 6 months, you would not see much, even though you were appropriately loaded at the beginning. You're probably needing to increase that, as you get stronger and as you get more hypertrophy, right?
Yeah, and people even do it in studies. There was a tendon study done years ago where they lifted heavy or they did light with blood flow restriction. Every 2 weeks, they reassessed 1RMs in the heavy group and increased their load. In the BFR group, they never changed it the whole time. So, it's almost like people are like, well, I'm doing BFR, so I don't need to worry about the load. No. If they complete all the volume that you prescribed, and typically it's 4 sets, if they do that, next time you got to increase the load just like you would with any resistance program. Getting back to
so we have ACL reconstruction's a no-brainer. How soon post-op on that?
Well, I mean, it depends on your comfort level, your doctor's comfort level, your patient's comfort level. When we started it at our center, it was really interesting because we had these destroyed, mangled limbs with muscle flaps and X-fixes on. And our guys were, our trauma surgeons are like, yes, get this BFR on them as soon as they get in your clinic, Johnny. And then our ortho sports docs, when they started getting involved in this, they're like, I want to wait at least a month, And we're like, well, we're kind of missing the window here, but they're nervous, they went into this repair and it's hypoxia. And so now, I myself and many of the people that I work with, we're starting it within that first week. You want the knee to be calmed down, and no one's going to want a tourniquet and a lot of, pain and suffering that goes along with BFR if they got a pissed off hot knee. So you get that thing calmed down.
Right.
And then the quicker you can get it on, the better, because what we know, it's called anabolic resistance. And that's basically the muscle physiology term for atrophy, is anabolic resistance happens quick. That's the first few weeks. The muscle is just dumping like crazy. I mean, at 2 weeks, you're already down 30% strength, and you've lost more than the size of your heart in muscle tissue on these anabolic resistance trials in your thigh muscle. So if you can slow that train down, so I'm a real big advocate of getting it on early. I think you're going to see a lot of bang for your buck there. We haven't seen adverse events.
Do you do e-stim with that?
We do, yeah. And we're starting to see more trials come out using e-stim, and it's fantastic. So if you look at kind of the phases of how you would do blood flow restriction clinically, when they can't really do any load at all, just getting the tourniquet on them and inflating it and deflating it, typically it's around 3 rounds, can slow atrophy. And that's been shown in several trials now, that you can have this slowing of atrophy, and even a biopsy trial that did that compared to no exercise and people that were immobilized. When they biopsied it, the muscle fiber was half as much atrophy than the group that didn't do BFR. So it slowed it by about 50% those first 2 weeks. So you can just slow it down with a tourniquet. But as soon as you add a contraction, that's when you start to get these, the fast twitch metabolism. That's where you can maybe drive some of that muscle protein synthesis. And so e-stim's a great way to go at it. The couple studies that have done it with blood flow restriction have shown that it's done better than just E-stim alone. Because I think that hypoxic state, and if you're cranking your stem up high enough, we always call it University of Delaware levels, because they taught us you got to really crank it there. Then
Right.
you can probably start switching into more of that fast twitch metabolism. So I do love E-stim early on, and then as soon as I can get them loading light, I get them loading light with it to really drive where BFR shines, and then as soon as they can handle load, I get them off BFR and start pushing load. And that might not be with me. It might be get to the gym, or if my pro athletes, let's get you to the strength coaches now.
That's fantastic. Run down the other list of let's start with the heavy hitters in the research, that other conditions that this is great for.
Yeah. So, like I said, knee pathologies are one of them. Now we're starting to see more total joint studies come out. One of the guys that's part of our group, he's an orthopedic surgeon in Germany, Alex Franz. He starts blood flow restriction within a day or two. He came on our podcast and discussed his protocol for that a day or two after his joint surgeries. He has published trials that are, one's out now. He has multiple going on with total joints and really seeing, and it looks like some fantastic results with them as well. The lower limb conditions, I think, are the fantastic ones, because normally they're immobilized in a cam boot. And so you think something like Achilles repairs. HSS has done an Achilles repair study. Houston Methodist has an Achilles repair study that they just tease the interim analysis at AOSSM, and it looks like it's going the right direction. So those where they can't do anything at all, where they're immobilized, even if you're doing BFR on the thigh, just that tourniquet hypoxia might preserve the muscle in the lower leg. And what we can talk about maybe a little bit later, what that Methodist Achilles trial showed, which validated a previous ACL trial, it preserved the bone stock as well. So we might be also looking at, is this something we can do for bone?
That's incredible. So, if we talk about it, we've talked about, okay, here's some uses that are very clear in the literature. When shouldn't we be doing this? Like, what are the things that you're saying, gosh, I don't, because I think a lot of times people think, okay, well, they have a post-surgical, they're post-surgical, so I want to wait, like we said, 3-4 weeks afterwards. You're saying that's really not the case. Trials don't indicate that. But what are the things that I'm like, man, I'm not going there with this?
Yeah. Well, for one, it's not even from a safety concern, but if they can lift heavy, they don't need it. And adding BFR to lifting heavy, there's no additive benefit that we've seen so far. So if they can lift heavy, have them lift heavy, save your tourniquet for your other patients. But some things, like if they have an active VTE, or a clot, then those patients should not be doing blood flow restriction until cleared by their medical team. If people ask me, when should they start it? We don't know. The APTA's new CPGs for VTE came out, and they're pretty aggressive on how we should be mobilizing people that have these things now. And once their INR is up, they're at a therapeutic level, we can probably do more aggressive exercise with them. So if you clear with the medical team, their INR is there, that would be where you can do it, but don't touch them until you discuss it with the medical team. People that have, kind of a really out of control hemodynamics, so severe hypertension, when you do blood flow restriction, you reduce the arterial flow, and then you block venous return. And so that does a couple things. One, it kicks off the exercise pressor reflex, which means blood pressure will go up. And blocking venous return, you're reducing stroke volume, which means the cardiac output is heart rate times stroke volume. So heart rate goes up. So the hemodynamic load is higher than lifting light. So it's going to be a little bit more from a heart rate and blood pressure workout, even though they might just be doing some light, long arc quads or something like that. So those individuals with heart conditions, cardiovascular disease, we don't know yet. We have some studies going on down at the University of Miami and the VA down there that look promising, even for heart failure. But right now, those are ones we don't know. Yeah. And that, the initial results on the people with the worst ejection fraction seem to be doing the best with it, which is pretty cool. But the hemodynamic load is less than lifting heavy. So just being aware that this could also be an avenue if you want to introduce resistance exercise into some of those individuals. You get cleared by the medical team. This could be a way to get at that muscle without a really high hemodynamic load, which you get from an ACSM guideline lift. So it could be a way to ease into them. We don't know with cancer yet. Not enough clinical trials. So those patients, we don't know. And of course, pregnant women. No one ever looks at them.
Yeah, that's the standard.
It's the standard of rehab. Poor pregnant women. No one ever is like,
you can't do anything.
No one will study.
Now you're going to get me in trouble with every person who does rehab with pregnant women. That's going to now send an email that says there is so much you can do, and we do know that. So, but there are a lot of contraindications.
I believe them. It's just when I look at the studies, I just can't.
But it's on every list. I think it's just on every list.
Yeah,
Absolutely.
Yeah, they make us do urine tests in our trials, to make sure they're not pregnant, even though that's not an outright contra. Yeah, but those are some of the ones in the top of my head who would probably not be a candidate. But we've even we have a trial in the DoD with femur fractures, and so we're putting it over a frank femur fracture with an incision, and we've had no dropouts from not being able to tolerate the tourniquet. So,
wow, yeah, that's fantastic.
Yeah.
So now we talked about a lot of different mechanisms from the heavy strength perspective. We even talked about just inflating the tourniquet helping reduce that atrophy and things like that. But it seems like you're talking about also some pain control potential. Talk about that.
Yeah, it was very interesting when we first started doing this at our center that we were seeing an analgesic benefit. So our service members would say, "Man, after you did that, my knee felt really good for hours after, sometimes even the next day." And so one of the problems with tourniquets is they are known to be a pain producer. One of the main reasons your patients have postoperative pain is not just the incision, it's actually from the tourniquet. So our first study we did at the center is I looked at, does BFR in postoperative patients increase or decrease pain? And it actually decreased pain in 4 weeks. And so we had multiple other groups tell us they were seeing the same thing. Some work came out of Aspetar over in Qatar that showed with anterior knee pain patients, they were getting this analgesic benefit. And so we had a postdoc at the time, Dr. Luke Hughes, who we tasked to kind of look at mechanisms. And so he looked at some of the mechanisms of why people are getting this analgesic benefit. And what he found is compared to lifting heavy, lifting light, or doing BFR, 2 different pressures, BFR at a higher pressure, the pressure we recommend in lower extremity, elicited the biggest pain response. And when they looked at the factors that might contribute to that, they saw a really nice increase in what's called beta endorphin in these people's bodies. And beta endorphin is an endogenous opioid that's in your body. And beta endorphin, what it does is it kind of follows the lactate pathway. So if lactate starts to go up, your body starts to release this endorphin. And you can think about it almost like a runner's high. And it's an evolutionary kind of protective mechanism, because if you were a caveman and you were building up a lot of lactate, you were probably doing something really rough. You were fighting a dinosaur, or you were like in a war and like that. And the last thing you want to feel is your little Achilles tendinopathy. So as the muscle was building up that lactate, your body starts purging out this beta endorphin. And you build up lactate when you lift heavy. But what's probably different with blood flow restriction is we don't release the cuffs during the rest periods. So all that lactate stays in that limb. And you keep building it up. That's why BFR is so hard, because you just have this massive pulling of lactate. But what it does is keep driving that endogenous opioid and the analgesic benefit. And so that makes sense.
So you mentioned tendinopathy. Sorry, yeah, you mentioned tendinopathy in there. What's the research on does it have tendon effects? What load do we? What does the protocol look like for that?
Yeah, so there's a systematic review and meta-analysis that looked at it and said, yes, BFR works for the tendon. We were, blah, 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 positive changes. And getting back to our systematic review and meta-analysis, when I read it, they put all these papers in there. And I was like, this is a joke, because only 2 of those papers were good out of the 6. So that's one of those you can throw out the window. But the 2 that were in there were really good. And it's from Chris Sentner's group in Germany. And so they've looked at the patella tendon and the Achilles tendon over 12 weeks of lifting heavy or lifting light with blood flow restriction using shear wave elastography. And what they have seen is that the adaptation, not only at the muscle, but the tendon for cross-sectional area and stiffness was equal and significant between the 2 groups. So there is an effect not only on the muscle, but there's an effect on changes in the tendon, which for me, I think is fantastic because, I can count on maybe one hand how many people stick to my eccentric loading program for tendinopathy. It's just a pain in the butt to do. But if you can say, well, come to my clinic, over a short amount of time, hopefully I can increase not only your muscle strength, I can increase tendons, stiffness and cross-sectional area, and I'll get you an analgesic benefit while you do it, which is reverse of the tendinopathy, heavy loading programs. It's like, well, let's make it hurt, which is hard buy-in. I've seen really good results in a lot of the teams I work with as well for tendinopathy. I think it's very positive. I have a slide where, I just listed, this year, the clinical trials that are looking at tendinopathy and tendon problems with blood flow restriction. I think it's like 22 right now. So there's a lot of interest out there. People are seeing something with it.
That's fantastic. So you talked about, teams you work with and things like that. Blood flow restriction. What are you seeing on the recovery side of things? How does it work for recovery, and how do you use it for recovery?
Yeah, I might speak more on this at conferences and with teams than I do about blood flow restriction for clinical rehab now, because it's kind of the hot thing. And so basically there's this thing called remote ischemic preconditioning. And RIPC is putting a tourniquet on a person, inflating it to 100%, leaving it on for about 5 minutes, deflating it, and repeating that a couple times. And that started to see if you could cause enough stress in the body that you could protect organ tissue. And so it started in dogs at University of Washington in the 90s, and they showed if they would do that and then clamp the artery off in their heart for about 40 minutes, the dogs that they preconditioned, it actually spared the heart by like almost 70%. And so now if you Google Scholar or PubMed, remote ischemic preconditioning, you're going to get a ton of papers that are looking at for everything from stroke to liver transplants to heart surgeries. I mean, it's just a huge thing in medicine right now. It also is protective for muscle, it appears. And so there's been some studies where if you really break someone off, so have them do, soccer or do, 100 box jumps for plyometrics and destroy their muscle, and you remote ischemic precondition them before or after the event, there's this protective effect that seems to happen. And when they do blood draws and they look at creatine kinase, those levels are significantly blunted. So we're not seeing, frank signs of muscle damage. When you look at DOM scores DOMs, or just looking at pain scores days after, that's significantly blunted. And when you look at return to strength, it's days faster than if you didn't do anything after the event or before the event. So from a recovery standpoint, that is something we're doing quite a bit with the teams, where post-game, especially with these high travelers, like I have, I'm an NBA guy. I got a game on Wednesday. I got a game on Friday. I'm going to be kind of broke off. Okay, let's get the RIPC on you after the game. And, within about 48, 72 hours, we hope your MVC's back. It's even so the Houston.
Yeah, well, it's interesting that you say pregame. Not that we would probably ever do it pregame, I would imagine, but you're saying pre-competition, pre-stress, kind of almost probably applying the literature from the organ salvage kind of concept that it's so probably the post-game helps for the post-game, but also is doing a little bit of that conditioning to that response for the long-term benefit of it as well.
Yeah, that's what I say. Like the Houston Texans now, I mean, we worked with them. They've built out a whole BFR RIPC room in their new facility where their players are doing it throughout the week just to precondition them and get ready for the games. And they're doing pretty good this year. So I'm saying it's all right.
Well, we won't get into football. That I would love to, but that's we're not going there. All right, let's take this to some case examples. Do you have the specific cases that we can kind of talk through to kind of make sure we understand exactly how to apply this?
Yeah. So I think just building on what we talked about, I'll talk about an orthopedic case and then maybe go a different way. There's a new technique with Achilles repairs now, a speed bridge. So it used to be you would get an Achilles repair, you're in a cam boot, and a doctor would kill you if you plantar flex that foot for the first 6 weeks. Now, with this new technique, you can be a lot more aggressive, at least in the ability to do range of motion, so some light range. And so, a couple of cases now in the NFL with Achilles repairs, and we work closely with the doctors that work on these patients. We get the tourniquet on right after the repair. And so they're just doing that remote ischemic preconditioning. And they're even though they can't do any calf exercises the first few weeks, we're using that to slow that atrophy. I said the muscle fiber loss was less than 50% compared to without. So they're slowing the atrophy. They're also doing some things to keep their thighs strong. But then they're allowed to start doing some light plantar flexion, even with a little bit of TheraBand. That's just made for blood flow restriction right there. That would be, like my scientist said, glorified range of motion back in the day. But if you put a tourniquet on, that light exercise, now all of a sudden we're getting the fast twitch fibers. And then as you can put them maybe on a leg press and load it a little bit more, then, you're really getting where BFR shines. Here's the deal. We know the Achilles will repair in about 6 to 8 weeks, right? Especially with this new technique. The tendon, we know tendon healing, it heals. The problem is it heals, and then when they get out of that cam boot, they got a tibia for a muscle, right?
Right.
And so all you're doing is waiting months to try and get that calf muscle back if you can. But if we could keep that calf muscle on and the repair is solid, then what's holding us back from running at 8 weeks or practicing at 10 weeks? And in this case, the most recent one, this guy was already running at around 8 weeks and was cleared to practice and was maybe going to play with his team. They didn't make the playoffs, at that 12-week mark. And he's playing now and doing just fine. So that's where I say we can really maybe speed up timelines, because if we keep the muscle on, once the bone heals, we know it heals. If they got a muscle, what's holding them back? Let's go, man. It's 8 weeks. We don't need to wait another 3 or 4 months.
Right. Absolutely. Oh, that makes sense. So that's just a very clear application of multiple principles that you just discussed throughout this episode. What other cases does it come to mind?
Well, I think another one that's different is it's a study that just finished and published this year out of Baylor. But I think it's a case example that's fantastic and people might not think about with blood flow restriction. So it was with Parkinson's patients, and Parkinson's patients have really bad vascular systems, and it's primarily from their drug. They have to take levodopa, and as they get further along in their progression of Parkinson's, they have to take more and more and more levodopa, and their cardiovascular systems just go kaput. They call it the purple hand syndrome because their toes and fingers become real purple. And so what was done by the researcher and colleague of mine, we kind of helped her build this protocol, was twice a week for 4 weeks. 3 times a week for 4 weeks. They did blood flow restriction. They did upper body exercises. They did lower body exercises. And the primary aim of this study was not increasing muscle strength and hypertrophy, although that happened. The control group was lifting heavy. They both increased that significantly. But the BFR group after this period had significantly improved vascular systems. So their reactive hyperemia index, which is how well basically blood perfuses into your limbs, increased by almost 50%. It didn't in the lifting heavy group. Their endothelial compliance, so the pliability of their vessels, their large vessels, improved. Their homocysteine levels, which is a marker of severe cardiac events, dropped below that threshold of severe cardiac event risk, which they were all above before. So applying BFR for this very short 4-week window in these kind of severely compromised individuals completely remanufactured their vascular system. And she has these fantastic...
Which harkens back to what you said about, our cardiovascular, those with cardiovascular disease, maybe it's a risk factor, or maybe it's a bridge to actually returning the hemodynamics of the entire system. That's incredible. And really speaks to the whole pervasive physiology that occurs with blood flow restriction.
Yeah. And what's beautiful, I don't have to say it's magic, because I can cite you the mechanistic studies that have looked at why this would happen to the vascular system. From hypoxia to the shear stress of the tourniquet being released. There's the Nobel Prize was giving for these gentlemen that figured out hypoxia can release this thing called HIF-1A, which increases capillarization, which is VEGF. So we're standing on the shoulders of giants. I can explain it mechanistically. I never really feel like I have to shrug my shoulders. And then we just have these trials that are backing up what we see. And feel like that study, if we can get a larger trial, is a Medicare-ready code. because how amazing would it be if we said as physical therapists, I'm not only going to increase your muscle strength and size, but it's 4 weeks. I can give you a complete vascular tune-up potentially. That is, we're really doing something medically now. If there was a drug that said,
it could do that, right?
I can increase your strength, I can increase your muscle size, and I can improve your cardiovascular system, it would be a multi-billion-dollar drug. And we potentially have that in our hands.
That's incredible. That's a huge impact. And so, I mean, let's talk about that impact. If we were to kind of like summarize this show a little bit, what would be your 3 top actionable takeaways that people should take away from this and know about blood flow restriction?
Yeah, I would say don't be afraid to do it. The science behind it is very strong. We can back you up with a lot of published trials and a lot of not only published just research, but clinical trials. So the science backs you up to do this. You're not doing some crazy voodoo type thing. I would say it's not only for muscle, that there's a lot of potential that we're seeing for things like potential bone healing, for tendon, for the vascular system. So, if you have some of these patients that have these conditions, if everyone's good with you doing it, they might be worth trying this on as well. And I would say just it's easy to get excited from this, and I'm easily excitable. I'm probably, everyone's like, what does it not cure? And I'm like, there's a lot,
Right.
I just get excited talking about it. So I can get carried away, but, make sure that you are, competent in doing this. There's all sorts of courses out there. We have a course, but there's ways to make sure you're competent. And also I think, we need to really think about how we're applying it on these folks.
That's awesome. Well, I certainly think you and I could sit down and talk for hours, but unfortunately, we're kind of limited on time here. So to wrap things up, what have you recently read or learned that you would like to share with people?
Yeah, thank you for sending me this question ahead of time, because I hate these questions, because I typically
right.
I just sit there and stare like the Zoom.
It keeps from happening. Yeah.
But I was finishing up a book at the time. I'd read it earlier and I reread it, called 4,000 Weeks. I don't know if you've heard of it.
I have.
Yeah, it's really cool, man. And so 4,000 weeks is basically the amount of time most of us will have on this earth. And so if you look at it in days, or months, or years, it doesn't hit you. But for some reason, that 4,000 weeks hits you. And I'm probably over halfway there. I'm in my 50s now, so I've got less of that time. Yeah. So, and it's not a book about like live your best life or do anything. It's like accepting your finitude. Like, you have a finite time. You can only do so much. You need to make decisions. Some of us hem and haw. Once you make a decision, you close the door. When you marry your wife, you close the door on all those other women out there, but you only have a finite amount of time. So make these decisions and move on. So I thought it was super empowering. And I've even got a mortality countdown timer on my computer, just so I think about what.
Well, that's great. I love that. I'm gonna have to reread that. That was a good read, but it's been a minute since I've read that.
He's got a new book coming out next month as well, so it's worth it.
Oh, okay. So maybe it's perfect time for a reread. So that's great. Good deal. Well, how can people connect with you?
Yeah. So I have a company that focuses on blood flow restriction. It's owensrecoveryscience.com. We have all sorts of blogs on there. We have our own podcast. So if you love hearing my voice, or you want to hear from BFR experts or teams or healthcare systems doing it, check out our podcast. But you can get in touch with me through there. I'm the worst social media person in the world. So if you go there, I probably will never know that you do it.
You actually did it, right?
Yeah. I'll let you guys, if y'all want, in the show notes, put my social feeds on there. But I don't even know what they are.
That's fantastic.
Yeah, but
lots of good ways to connect with you. If you'd like to connect with me, you can find out what I'm doing, what I'm learning about at philplisky.com. But that's all the time that we have. Be sure to check out Johnny's course on blood flow restriction with ACL reconstruction. It was part of our summit that we had put together, and I think it really was a great compliment. A lot of insight from that course. So be sure to check that out. Thanks, Johnny, for being with us today.
Awesome. Thanks for having me, Phil.
Fantastic. Well, until next time, let's keep building the future of rehabilitation and performance together.
Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com. See you next time.